Okay, so let's go through the urinary system. So what it does is that it filters blood. It removes the excess water solutes and allows us to store urine that produces and allows us to voluntarily urinate. So so body regulates blood pressure. And this is influenced by the volume of blood that you have. And your blood is mostly made up of water. If your blood pressure is high, your kidneys of the urinary system will pull out water out of the blood, and you have to urinate to reduce your blood pressure. It regulates the blood pH, so kidneys can selectively remove hydrogen ions and bicarbonate ions out of your blood, which will influence the pH of your blood. Excess ions will come out of your urine. And it regulates how much glucose is in the blood. And it creates glucose from amino acids. So if the proteins are broken down, urinary systems are capable of doing glucogenesis, which is when you make glucose from something else. So the urinary system regulates the blood ion content like sodium, potassium, and chloride. And if you have too much of those, it will be excreted. So it's part of the endocrine system and produces hormones like the calcitriol, erythropoietin, blood formation, calcium, it pulls the waste from and excretes like ammonia, urine, and creatinine. So let's go over the functions. So excrete waste, regular blood pressure, regular blood pH, regular blood glucose levels, regulates blood iron content, and it also kidney also produces hormones. So the anatomy of the urinary system is that we have two kidneys, two ureters, and a single urinary bladder and urethra. And this is kind of like a cadaver looking at it. Okay. So most of the work that goes on in the urinary system is done by the kidney. And because the kidney is retroperitoneum, which means behind the peritoneum, and it is the serous membrane that lines the abdominal pelvic cavity. So the renal hilum is the indentation of the kidney. The renal artery is the main artery of the kidney. So it has the renal capsule. So there's a tissues layer surrounding the kidney. Okay. So it has the renal capsule, which is the exterior layer of the kidney. It maintains the kidney shape and it has a fibrous capsule. We have adipose capsule, which is the adipose tissue, and it prevents padding to protect and cushion the kidneys. And we have the renal fascia, which is dense, irregular connective tissue that holds kidney in place in abdominal walls. And 1 in 4 people have nephroprothosis, which is where the kidney falls out of position on the back or posterior of the abdominal wall because the renal fascia just weakened and the kidney drops in the abdominal cavities and causes the ureters of the tubes that carry out of it to it can cause like blocking urine and can rupture a uterus. Okay, so we have the renal cortex, right? And the renal medulla, which is the inside of it, and the renal lobe is the single unit. See? Single unit, this whole thing. While the pyramid is this. Okay, so the kidney internal anatomy. So it filters blood to make urine. Urine is going to leave the kidney, and the nephron makes urine and goes to collecting ducts and drain the calyces. The nephron is filtering out blood, and capillaries are coming in and make urine. So there's calyces merge together and dump that urine into the renal pelvis. Okay, so I'm gonna go over this slowly with you guys to make sure it makes sense. Okay, so filtered blood is what makes urine, right? So the urine is going to leave the kidney. It's going to go to the collecting ducts, which is over here. These are the collecting ducts. And then it will go and drain in the calyces. Calyces are over here. Okay? And then it'll drain to the renal pelvis. It's kind of like like a small version. Renal pelvis is over here. Right? And from the renal pelvis, it's going to leave the kidneys through the ureter, which is over here. And nephron is filtering out blood, and capillaries are moving in to make urine as the filters move through the nephron. So multiple nephrons feeding into collecting ducts and drains urine in cup-shaped called calyces. And the tip of every renal papillary sits inside a calyx. The calyces merge together and dump that urine into the renal pelvis, and basically a chamber in that hilum of the kidney and renal pelvis drains urine out of ureter. So let me explain it, okay? So it was um nephrons, right? Nephron, collecting duct, calyx, renal pelvis, ureter. Nephrons filter blood in renal corpuscle. So efferent arteriole goes in the capillary bed called glomerulus, and it goes back to arteriole that leaves the called efferent arteriole. So the kidney receives about 25% of blood flow, and the pathway to kidneys into glomerulus for filtration and back out kidneys. We have renal blood vessels, right? And the coming off the abdominal aorta is going to be the renal artery. Blood after it goes into kidney and filter is going to be go to renal veins, which will return the blood into a inferior renal cava. Okay, so the renal blood flow is this. So abdominal aorta goes from the renal artery to the segmental artery, which goes to the interlobar artery. So segmental is over here, right? Segmental, interlobar, arcuate, cortical radiac, and then it goes to afferent artery. Wait, sorry, afferent arteriole, and it goes to the capillary beds called glomerulus, where the blood is going to be filtered by nephron, and what doesn't get filtered goes to the efferent arteriole, which goes to the second capillary bed, and then nephrons put anything into the capillary bed that did not want to secrete in its urine. And there's a particular capillary over here, which is the extension, and it goes down a loop called vasa recta. This is the vasa recta. Then it goes back, cortical radiac, vein, arcuate, right here, down into interlobar, and then to the renal. Yeah. Okay, so the each kidney has about 1 million nephrons, and you don't make new nephrons as you age, but so you can't replace them. So once your kidney is removed, the other kidney does enlarge it. So we have the renal corpuscle, which is the round and enlarged portion at the start of the nephron, and the renal tubule, which is the long skinny extension. So the nephron has two major parts. We have the glomerulus, which is a tiny capillary bed, and the glomerular capsule, which surrounds it on the inside. So it's a Bowman capsule. It's made up of the double layer of epithelium. So talking about tubules, we have the proximal convoluted tubule, which twists and turns, and the nephron loop, which is kind of like the hair loop, and a distal convoluted tubule. And the renal corpuscle and the ascending limb of the loop comes into contact with the efferent arteriole that extends into glomerulus. So we have the juxtaglomerular apparatus. Okay. So, and then in the nephrons, we have the renal cortex, which is the renal corpuscle, which has the DCT and BCT. And yeah. So let's talk about the cortical where is it? Sorry, that was a little off. So renal corpuscle right here, renal tubules down here, and then renal corpuscle, and renal tubule, and then juxtaglomerular apparatus right here. Hmm. Okay. I think we have the PCT right here, PCT here. Yeah. Okay. So we have the cortical nephron, which is the most common nephron. It makes most of the urine and it's in the cortex. It's towards the outside of the kidney. and the loop is quite short and barely enters the renal pyramid. We have the juxtamedullary nephron, which is in the renal cortex. And the loop and so it makes concentrated or dilute urine and it's used during time of stress. So if you're stressed, you will make concentrated urine so you don't urinate all the body water. You have too much water going to it will shock and then so that's why so basically the juxta cortical makes the urine while the juxta makes concentrated or dilutes the urine. So first, second. No. I'm trying to think of the alphabet. Like C goes first, so C makes the urine, you know. Okay. We have the glomerular capsule, and this one is a double layer of simple squamous epithelium. And then part of the nephron, we have the parietal layer, which is the exterior surface, and the visceral layer, which is the inferior surface that touches the glomerulus. It has special cells called podocytes, which are the squamous epithelium called cells of visceral layer, and it's important for the filtration of blood. And between the parietal and visceral is the capsular space. So it collects the filtrate that the glomerulus and nephron filter out of the blood. So liquid from the blood minus cells, yeah. So we have the parietal layer outside and the visceral inside. Podocytes are over here, and the capsular space, which is over here. Collects filtrate. Okay. Let's talk about radiotubule. Okay, so it does vary around the renal tubule. It's a lot, but basically, right? So the PCT, proximal convoluted tubule, how can you tell? It has microvilli, so the lumen is not very clear. The nephron loop would have simple squamous, and then the nephron loop, the thick one, would have simple commotile with no microvilli. The distal convoluted tubule is just simple commotile. This one has no microvilli. And then the last part of the distal would have simple commotile with some prominent microvilli. Okay, and then the juxtaglomerular apparatus. This one has macula densa, which are specialized cuboidal epithelial cells in the nephron loop. So it makes up the wall of the nephron loop where it touches the efferent arteriole and senses filtration. Um, senses when filtration slows in the nephron and releases nitric oxide. We aren't getting blood flow because we aren't making urine, so it's releasing nitric oxide. So nitric oxide causes the capillaries to dilate to fill with blood and increase blood flow to glomerulus and increase filtration in nephrons. The releasing of the nitric oxide, all the blood vessels in the capillaries will get larger and more blood will come in, and the rate of filtrate is going to increase and make more urine and turn off the macula densa. So increase urine flow if it drops. So basically, macula densa kind of like filters the nephron and then releases the NO. While the juxtar glomerular cells, these ones are the special muscle fibers in the arteriole. It talks to the nervous system and it senses the blood pressure. It senses when the blood volume is low, and if it's low, it will release renin and go throughout body to increase the blood pressure by slowing rate of urine. And they work in opposition, so senses blood pressure and decrease urine flow if it's low. So glomerular filtration. So the renal corpuscle filters blood plasma, and it protects along the renal corpuscle to prevent blood cells from entering the anemia. Okay, so okay, let me explain this one. So renal corpuscle, right? This one is glomerular filtration has renal corpuscle that filters the blood plasma and prevents the blood cells from entering the nephron. So if you see blood in urine, it means there's damage to your renal corpuscle of your nephrons. We have tubular reabsorption, which is all the blood, liquid, water, ions, and tiny proteins all goes into a glomerular capsule. And you don't want to lose all of it. So you flush everything out your glomerular filter, you have to constantly drink water, right? So that's why it reabsorbs useful substances back into your bloodstream. And there are transport pumps taking it from the filtrate and putting it back in the capillary bed. Tubular secretion pumps secrete specific wastes into your urine. It has metabolic waste like urea, toxins, and drugs. And over a day, glomerulus filters 150 liters of blood liquid, but we only excrete 1 to 2 liters of urine. So renal failure is the disease decreased cessation of the glomerular filtration if the nephron stop filtering blood. So if it's sudden, it could be acute renal failure where you stop urinating and caused by trauma where the kidneys are. And the chronic renal failure is when the kidneys enlarge, so you don't see the cessation of urination when you're in the late stage. So we have edema, right? Which is, so basically it's fluid retention in the tissues because the kidneys, okay, so you know how we talked about the glomerular filtration was doing important things? Like they were making sure you reabsorb the substances in your water and also filtering the blood plasma, right? Now that doesn't happen anymore. What is it gonna cause? Renal failure. It's gonna cause edema, which is fluid retention in your tissues because the kidneys are no longer pulling excess water out of your body. It's gonna cause metabolic acidosis, which is the blood that is acidic, and urinemia, because you have urea accumulating in the blood, which can cause cardiac arrest. Too much potassium and if there's too much potassium in your blood or not enough sodium enters the calcium deficiency because the kidney produces calcitrol. So the treatment we have is dialysis, which is the blood is artificially clean. It removes excess urea and iron and balance on. You have the hemodialysis, which filters filtration by filters in the hemodialyzer. It immerses filter in special fluid, draws extra urea and ion concentration, and uses the concentration gradient to remove ions and metabolic waste. And you have to do this 3 times a week. So, so basically, um, the blood is artificially clean, right? So you take all the blood in, all the blood out, and just filters and cleans it up. And then peritoneal dialysis, this one inserts a catheter in the peritoneal membrane in the cavity and is attached to a solution bag filled with dialysate, which is a fluid that has low amounts of urea and low concentration. And it will draw out any urea, the waste products, and gets empty out of the bag. It causes high risk of peritoneal membrane infection, and the abdominal can swell up. We have kidney transplant, which is where if the histology compatibility matches. So what they do is they don't remove the old kidneys unless it's infected, and they'll just implant both kidneys. So you have like 3 kidneys. And they'll put it in the iliac crest. So the urinary transports urine from the kidney, stores it, and controlling when you release. We have 2 urethras, right? And 1 foot long, and they are urine is pushed down the urethra by peristalsis, similar to food, and there's no valves. So the moment the kidney makes urine in renal pellets, it just goes straight to the bladder. We have mucosa, which is 2 layers of epithelial tissue surrounded or covered by connective tissue. Epithelial tissue is made of transitional epithelium and it allows for stretching. It looks like cuboidal shaped cells, and its transitional epithelium held in place by a thin layer of lamina propria that holds all epithelial tissue to the next layer out. We have muscularis, which is the 2 layers of smooth tissue. Smooth muscle. So the deepest is longitudinal and external is circular, and the longitudinal is closer to the lumen. So along the distal third of the ureters, as you get closer to the bladder, you see additional third layer of longitudinal muscle controlling the ureter. And then we have adventitia. This is the outside layer, It's a thin layer made up of areolar connective tissue and it connects to adipose tissue that lines body cavities. There's a lot of blood vessels, nerves, lymphatic systems, and anchors ureter in place so it doesn't shift in the abdominal pelvic cavity. The bladder is anterior to the rectum, right? A female bladder is inferior to the uterus. It's surrounded by a peritoneum and holds 3/4 of layers, but women hold less to accommodate for a uterus sitting on top. So a pregnant woman has to pee a lot because the fetus will sit on top of your urinary bladder. We have a urinary bladder. It's a triangular space on the floor called a tryon. The points are made of the two holes of the bladder. The posterior two holes, and the tip is the interior ureter orifice, which is how the urine exits the bladder and goes into the urethra. And there's bumps and folds called urage, which allows for expansion of the urinary bladder. And it has muscularis right here, and right here. And it is longitudinal, circle, and longitudinal. The outside is adventitia, which is areolar connective tissue to hold it in place. The bladder has internal urethra sphincter, which is the ring of smooth tissue that sits in the base of the bladder. Internal right here. And males, it is used in the urinary and reproductive system, so it makes urine and semen. While the females use only urinary, there's a separate opening for the reproductive. And it has external ureter splinters, so skeletal muscle can be voluntary control. Men have to shake off extra urine because the external ureter splinters and stop the flow of urine from the bladder. There's still residue that needs to be secreted. The lining is mucosa, and it's lined with epithelium. It's close to the bladder and it's transitional to stretch. There's the middle, which is a pseudo-stratified columnar in the and as the external ureter orifice, it changes to stratified squamous epithelium. So in muscle areas, the men have smooth muscle near prostate, but skeletal muscle inferior to the prostate, while women have smooth muscle, and there's no adventitia. The bladder and urethra, men have additional reproductive glands like seminal glands, prostate glands, and ureter glands that have ducts that open up in the further. So we have the prostatic urethra, membranous urethra, and the spongy urethra. Okay. So internal urethra splinter. You have control over external but not internal. So when the urinary bladder is filled with urine, there are stretch receptors that signal the maturation center in the spinal cord. It occurs when the bladder is around 200 to 400 milliliters. It triggers the maturation reflex. So it relaxes the internal urethra splinter, which allows the urine to urethra, and the contraction of destructive muscle in the bladder, and inhibition of the external urethra splinter. It takes practice to voluntarily control the external urethra splinter. So what happens is there's a lot of pee, right, in here. It triggers the maturation reflex, which relaxes the internal, it contracts the detrustor, and inhibits the external. So as we age, your nephrons slow down, right? By the time you reach 85, you lost 40% of your nephrons, which means less filtration, more toxins, less urine formation, so you have a hard time regulating blood pressure. And prostate enlargement in men will close urethra and you can't urinate. There's treatments to shrink the prostate or slick a stent in it, and there's surgery like removing tissue of the urethra or removing testicles to shrink it down. So external urethra splinter becomes weak and it leads to incontinence and a hard time holding urine.